is a blinding light. I can barely see your faces, but it is so good to be here with you today. Wow. My name's Amanda Azadian. I'm the product manager for the digital health strategy team at the American Medical Association, and I'm joined today by an incredible group of physicians from across the country that we've been able to bring together through the AMA Physician Innovation Network. Now, the AMA continues to bring the physician voice to health. Over a number of years, we have been hosting the Physician Innovation Network to engage physician voices in emerging technology, seeking to bring better solutions to market. And that has continued as we're seeking to make those solutions work better once they're actually in the clinical workflow. So this panel today will discuss, we actually have a double header today for you. Surprise, surprise. In case you didn't notice that on the health agenda, we have a first panel discussing what physicians wish technology designers knew about their practice, about their workflow, about what it means to be actually implementing technology into their care setting. And then we'll have an extended time for audience Q&A. We were originally in a room that had breakout sessions where we could dialogue, and then they upgraded us to an even bigger room, and we're so excited that we can fit more and more of you here. But this will be a really great time to have a question for the physicians in the room and a question for the healthcare technology designers in the room to be able to have more of a dialogue. We'll conclude with a panel about digitally enabled value-based care and how we can stitch these things together, also by my AMA colleagues here. So I want to get a quick pulse on who we have here in the audience. So first of all, physicians, care team members, healthcare administrators, would you raise your hand? Okay, so I think we have about maybe 40% of the audience being represented by people that are doing the caregiving in the hospital setting or in another clinical setting. Companies, investors, accelerators and incubators, representatives of those organizations. Can you all raise your hand loud and proud? Amazing. Okay. Maybe like 15, 20% of you here are solution designers. What about my AMA colleagues? We have a number of folks here from the Center for Health Equity, Health Solutions, Professional Satisfaction and Practice Sustainability here, and these folks are here to talk to you about CPT, the work that we do in embedding equity into innovation. So for my AMA colleagues, would you raise your hand so that folks can know who you are, where you are? Okay, they're sitting close to the front, just like I asked. Thank you all for being here. So this program is the next evolution of the Physician Innovation Network, as I mentioned. We have 20 physicians here today. You're seeing their faces up on the screen. And it's my pleasure to be able to introduce them. So first off, we have Salim Afshar, if you can raise your hand and wave, right here in the front, who is a head and neck pediatric surgeon at Boston Children's. He has a background in engineering, human psychology, global health, and both a medical and dental degree. He specializes in rare pediatric head and neck conditions and has developed a novel use for AI in his specialty. He's an author, mentors companies through the Harvard Innovation Lab, and is a member of the United Nations Innovation Exchange. He's the CMO of Reveal Health Tech, an organization supporting healthcare organizations adopting and integrating technology more effectively. Thank you so much for being here. Next, we have Michael Albright. And thank you for being here. And, Dr. Albright is an internal medicine physician completing a clinical informatics fellowship at the University of Kansas Medical Center. And his focus is on rural health, primary care, wound and hyperbaric oxygen, weight management. He is serving as a clinical champion for the electronic health record, implementation, and a medical director in hospice care. He's planning to launch a tech-driven primary care practice in Kansas City after his fellowship. So if you're working in that space, please find Dr. Albright. Adam Bennett. I can't see anything. You are in the fourth row. Thank you for being here. Hi. So Dr. Bennett is the medical director at Northwestern Sports Medicine in Evanston, Illinois. He's a team physician for almost all of the Chicago professional teams. So if you're a fan from Chicago, definitely connect with him. He is also assistant professor at Northwestern University and has been a part of the AMA Physician Innovation Network almost since its inception. So thank you for being such a loyal part of this program as it's evolved over the years. We have Dr. Shaw Brennan, who is sitting right up front here. Hi. Dr. Brennan is an emergency medicine physician serving as the Associate Chief Medical Information and Artificial Intelligence Officer at the Mid-Atlantic Permanente Medical Group. She is on the leadership team at the AI Center of Excellence, regularly contributing to their speaker series. And in case you're trying to take notes of exactly who you have to connect with, you probably got your badge scanned when you walked in the door here. And we will be sharing with you a directory of the physicians that got to participate with us today. So you can see their faces on the screen. I'm trying to point them out to you so that you can connect with them individually after this event, but definitely know that we will be sharing that with you digitally as well. Dr. Anu Dayal, hi. Dr. Dayal is a pediatrician and assistant professor of pediatrics at Stanford University School of Medicine. She is also a former medical device founder. So if you're working in that space, you can find her, commiserate. She understands your pain. She's also a clinical advisor at Stanford Biodesign and enjoys advising both adult and pediatric digital health, diagnostic, and medical device companies. Jonathan Handler is also right there in the front row. He's an emergency medicine physician and clinical informaticist, a senior fellow for innovation at OSF Healthcare, and has led innovations in medical informatics at Northwestern, Microsoft, and Baxter. He founded the section of emergency medicine informatics at Northwestern's University Feinberg School of Medicine. We have Dr. Karl Kokendorfer right next to him, also from Chicago, who wears a number of different hats at the University of Illinois at Chicago. He's the Assistant Vice Chancellor for Health Affairs, CHIO, and Associate CMO, where he founded and led many enterprise initiatives. So he cares for hospitalized patients and is a family medicine physician at the University Village Clinic, holding several informatics patents. So we have folks that are here to talk to you about what it looks like inside a healthcare organization and can talk to you about what it looks like to engage as you're seeking to implement. Dr. David Nichols, I want to point you out. There you are. Who is practicing family medicine at Jefferson Hospital. He also leads a healthcare technology meetup group in Philly, so if you're local to that area, you can find him. He also co-founded a value-based cardiac rehab and chronic care management company. So he also knows what it looks like to be a physician founder. Dr. Brett Oliver, who joined our panel earlier this morning, is a family physician and CMIO at Baptist Health in Louisville, Kentucky. He advocates for digital health policies through the ONC Federal Health IT Advisory Committee and through Epic's Care Everywhere Governance Council. Now, you guys know I need this iPad because there are so many incredible physicians that have joined us. We have Dr. Jessica Porian right here in the front row. She is an attending pediatrician and clinical informatics fellow at UCSF, caring for sick kids in both the office-based acute care setting as well as the emergency room. She has a background in brain and cognitive sciences and spent 3 years in healthcare consulting before jumping into medicine. She is currently focusing her research on patient rights, data privacy, and antibiotic stewardship in pediatrics. Edmondo Robinson is sitting right next to her. Thank you for being here. Dr. Robinson is an academic hospitalist at Moffitt Cancer Center, where he founded and led the Center for Digital Health and co-founded CancerX. For any of you who have participated in that program, welcome. It's great to have you here. Dr. Robinson is also a professor at the University of Florida's Morsani College of Medicine, and he recently founded an organization called Down East Digital, seeking to focus on embedding equity in innovation, where he's currently serving as the CEO. Dr. Srinivasan Suresh joined our panel this morning. Hi, Suresh. He is a pediatrician at UPMC, wearing a lot of different hats at that organization. He has a business background. He's a TEDx speaker. He serves as the chair of the Council on Clinical Information Technology for the AAP, and he's a professor of pediatrics and emergency medicine at the University of Pittsburgh. He's wearing a number of leadership hats, as I mentioned, currently and specifically as the CMIO at UPMC Children's Hospital. Dr. Michelle Thomas joined our panel earlier this morning, so if you were able to participate in that, she's right over there. Thank you, Dr. Thomas. She is a primary care physician and clinical informaticist focusing on ambulatory care and physician well-being. She is serving at BJC Medical Group. She's been in that CMIO role since 2011 and as the Associate Chief Clinical Officer since 2022. She serves as clinical faculty at the Washington University and focuses on provider efficiency and wellness, seeking to reduce the administrative burden. So if any of you have solutions that are seeking to reduce that burden, she's a great person to talk to about what really is meaningful in terms of those metrics. Reducing the cognitive burdens is something that our team is very, very passionate about, to those documentation and patient communication related issues. Dr. Caroline Yang, here from Boston, my hometown, is a hospitalist at Brigham and Women's Hospital. She's serving as the Associate Clinical Director for their Health at Home program. So she's delivering acute inpatient care directly into the home and serving as faculty at Harvard Medical School as a writer, advisor, and representative. She is really advocating in the health policy realm, both at the Mass Medical Society and within the AMA. Dr. John Dayton, who you will hear from on our panel today, is right here in the front row. Dr. Dayton is an emergency physician at Intermountain Health and faculty at Stanford. He's helping healthcare technology companies translate their digital therapeutics and AI operational tools into care delivery systems through the Stanford Emergency Medicine Innovation Symposium, which you might be familiar with. They have pitch events and other hackathons. He also co-founded Utah's Society for Physician Entrepreneurs, and he advises companies independently as well as through Intermountain Ventures. Jenny Beppel is right next to him, and Dr. Beppel is a urologist and clinical informaticist. She's very passionate about bringing that specialty care to those that need it and making sure that we expand that access. She's focused on patient safety, translating physician needs to tech solutions, and improving patient outcomes. She serves in various roles on medical boards and currently as the CMO at Ally Health. Michael Hahn, who's also here on the front row, is a urologist and clinical informaticist. He's serving as the CMIO at Multicare Health System, where he is also the interim vice president of enterprise applications. You'll get to hear more from Dr. Hahn on the panel that we have for you today. And last but not least, we have Dr. Hoberman, an internal medicine physician currently serving as the CIO for the Permanente Medical Group, managing technology, strategy, integration, and innovation. Whew, you guys, this is an incredible group. I'm so glad that you can all be here, and I'm seeing the room fill out. There's some more chairs if you want to come on up. There's plenty of space. It's really an honor to be able to double the size of this program this year. We brought 10 physicians to Health in the past. We sort of rapid fire introduced them to say, what do you wish healthcare technology designers knew? But what we want to do is really make sure that you understand who's here and get the chance to connect with them precisely based on what specific questions you have. So if you're a healthcare solution designer in the room, there will be time with a free mic to voice some of your questions. And then physicians and other care team members that are in the room, what we're hoping is that this is a forum for you to be able to share what you need, what it looks like for technology to really work within your practice. And we have physicians that are working on that from so many different perspectives. Some of them as the users saying, well, I really like my team and my human team that is working with me. We want that to be enhanced by technology so that we work like a more well-oiled machine. I've learned a lot about this space in the last year as we were able to bring on a new member of our team this year, Dr. Margaret Lazavatsky. She is a pediatrician and clinical informaticist that joined us at the AMA. Before joining the AMA, Dr. Lazavatsky was the CHIO for Novant Health. She's a nationally recognized leader in healthcare informatics, and she also serves as a member of the advisory board for the Association of Medical Directors of Information Systems, or AMDIS, if you're familiar with that acronym. In 2021, she was inducted as a fellow of the American Medical Informatics Association, and in 2023, she received the HIMSS AMDIS Changemaker in Healthcare Physician Executive Award. Dr. Lasovacki is one of the inaugural members of the Physician Advisory Board at Epic and currently sits on the Epic Physician Wellness Advisory Board. I'd like to invite Dr. Lasovacki up to share more about our digital health innovation strategy, and then we'll roll right into the panel. So thank you all so much for being here.
Thank you, Amanda. And thank you, everybody, for being here. And you're not kidding, these lights are bright. It is my pleasure to be the facilitator of this panel and of the activities that we're going to be doing here today. I am thrilled to have all of you in the room with us. And what we want to talk about is something that's very near and dear to my heart as I continue to practice and see patients, and that is making technology work for physicians and for all members of the care team, because we know that technology is integral to our ability to care for patients, and so it's really important for all of us to partner and work on making technology as much of an enabler for clinical care as we can. The AMA has conducted research to understand a little bit better what are the forces that are impacting the future of healthcare. And as you see all of these things on the screen, I really like this image because it reminds me of when I step into my medical hat when I walk into a hospital to care for patients. These are all of the things that I'm thinking about, and it is a lot of forces that are impacting our clinicians today. As you look at all of this, there's many questions that we have as we walk into the hospital that we're trying to process, and we call that cognitive burden. And it's something that we all experience and understand, and what our team at the AMA focuses on is how do we decrease that cognitive burden that our clinicians are experiencing. And we want to empower our physicians to optimize the use of existing emerging technologies. We want to ensure that technology truly enables us to care for patients, because that's why we went into medicine in the first place. And we want to help facilitate physician leadership in this space so that physicians have a voice in all aspects of technology life cycle. I want to back up a little bit and just give you a little bit of a framework of who this team is from the AMA and some of the other people that you're going to see later in the second panel. So this is a strategic framework from the AMA, and you see a few things on the screen. So the 3 buckets of work that we think about is the focus on decreasing chronic disease, removing obstacles, and professional development. And our team sits in the removing obstacles piece of this. We call ourselves Professional Satisfaction and Practice Sustainability, which is a mouthful, so we say PS2. And that is, the digital health team is one of the groups within PS2. So really, we are in the mission area focused on supporting physicians in their ability to care for patients. And the 2 panel discussions that you will hear from today, the first one is the Physician Innovation Network, which again is making technology work for physicians. And the second one is going to focus on the digitally enabled care to promote value-based care. And so both of these teams sit within PS2 in that removing obstacles bucket of the AMA. As I mentioned, we at the AMA do a lot of research, and as we asked our physician colleagues, what are the questions that you have when you think about technology? These are the 4 questions that they came up with. And this research was done in 2016, and we are looking to repeat it, and it will be interesting to see how the questions have evolved. But these are the questions that we consider when we think about the physician voice within technology. Does the technology work? And I think that question remains very pertinent in our clinical environment. Will it work in my practice? And we think about the various specialties that exist within healthcare. The needs of a cardiologist are going to be very different than the needs of a pediatrician or a urologist. And so that is a very critical aspect of how we evaluate technology. Will I receive payment, and will I be liable? These were the questions that were top of mind for our colleagues. And as we think about the development of technology, which is what we're going to talk about today, we always keep these 4 questions top of mind. As Amanda mentioned, I joined the AMA almost a year ago now, and we asked ourselves, what are the questions today? And we will continue to think about how these questions evolve. And we also asked, what are the needs today within our healthcare environment for physicians when it comes to technology? And we've been thinking about the evolution of those needs, and I want to share a little bit about the vision and the mission of our team, specifically within digital health. And really, I think the summary sentence at the top encompasses what we're trying to accomplish, which is make technology work for physicians. We want it to be seamless and trustworthy, and so we think about a time where technology will be reliable and again will enable our ability to care for patients, to achieve, and we say the quadruple aim, it's now the quintuple aim, but to provide care to our patients that is the highest quality, where we can improve patient satisfaction, clinician satisfaction, be as efficient as possible to minimize cost, and to be in a place where technology in the background is assisting us in the things that we need to do to care for patients. And we want to facilitate the optimization of healthcare technology. As we all know, it's not perfect today, and there's a lot of opportunity to continue to think about how to support our colleagues. We also want to think about innovation, and this is what this conference is all about. Where is the puck going, and how do we ensure that as we bring these technologies to the clinical environments, they are optimally integrated into existing workflows, and that we're thinking about the goal of the patient being at the end of all of this, and supporting our clinicians in all care settings. We know that a small practice and a large integrated health system may have different needs, and yet we want to support all of our physicians so that they can care for their patients. I want to take a minute to highlight the role of clinical informatics, and you've heard this term as Amanda was introducing some of the physicians that are here. Clinical informatics was recognized as a board-certified subspecialty a little over 10 years ago, and it's really important for us to think about how do we integrate the physician voice in the development, design, implementation, adoption of technologies, and how do we ensure we have the physicians that are trained in this field that can bring together the needs of the healthcare systems, the needs of our clinicians and our patients, and help to evaluate and design these technologies. And to help us talk about the role of clinical informatics and the role of physicians in this space, we are going to talk about today, what do physicians wish healthcare technology designers understood? And I know there's a lot of designers in the audience, and so I'm really looking forward to having this conversation with our fantastic panel of 4 physicians who I am going to invite to come up and join me here. I just heard someone else mention how bright it is. All right, well, thank you for being here and for sharing your time and expertise with our audience. I'm going to start by asking each of you to introduce yourselves, tell us a little bit more about your background, and share a little bit about your current role in your organization. And we are going to start with Dr. Dayton.
Hate to rehash since you got our intros earlier, but I'm an emergency physician with Stanford and Intermountain Health. My focus is on healthcare innovation, and I do that as an investor and also helping startups and more established companies build tools that'll be helpful for patients and physicians.
And I'm Jenny Beppel. I'm double board certified in neurology and informatics. And with that, dual background in clinical and technology and data, I support companies in bringing solutions that really matter to the healthcare experience. So I serve as a very proud Chief Medical Officer of Ally Health, where we have built out a clinical intake tool to improve office efficiencies and help physicians with some of the documentation burden that we've talked about.
Hi, my name is Michael Hahn. I am a urologist by training. I never thought that there'd be two of us up here, but I guess there are. So if anyone has a kidney stone, I think you'll be well taken care of. I am currently the Chief Medical Information Officer at MultiCare Health System. We're an IDN based out of Tacoma, Washington. I also have the privilege of serving as the Vice President for our enterprise applications, which is, for those of you who don't know, it's basically all the analysts that take care of our electronic health record amongst other third-party applications. As of now, I think that more than anything else, I'm focused on the blocking and tackling that needs to happen at a very tactical level at large health systems that have grown in an inorganic fashion, and the challenges that come with adding hospitals in order to achieve the growth that's necessary. And it's been a compelling challenge, and hopefully we can all together make a lot of meaningful change for our patients.
Hi, everybody. My name is Brian Hoberman. I'm a hospitalist by background. I've been working in healthcare technology for around 20 years. I work within Kaiser Permanente, where today I'm the CIO both of the Permanente Medical Group, which is the Northern California Medical Group, as well as the Permanente Federation, which represents all of the Permanente medical groups around the country. KP is a complex multi-entity organization, and I work with colleagues within Kaiser Foundation Hospital and Health Plan IT, who manage many aspects of our infrastructure. And together, between the medical groups and the health plan and the IT folks, we're responsible for all the care delivery, IT, and clinical equipment and so on that we use across the enterprise.
Thank you. Each of you wear a lot of hats, which is fantastic. And so you can provide some really interesting perspectives on this question that I want to ask you. We often, as clinicians, when we serve in an administrative role or in a leadership role within a company, have a lot of goals from our leaders that we're trying to accomplish. And sometimes they may be aligned with the needs of the clinicians, and at times they may be at odds with those needs. So can you share a little bit about how do you balance these conflicting needs of the clinician, sometimes the patient, and the administrative roles that you each hold? And we can go down the line, but please feel free to jump in if you have something to add.
We have an interesting lab at Stanford where we are able to help early stage companies focused on acute care, emergency medicine based, where they come to us and we partner with them. A nice thing about that is this is built around identifying the goals of Stanford, the goals of emergency medicine department, working with companies specifically that address those needs. And then it's a nice opportunity to give those companies some high level feedback, pilot what they're doing, and see if that's something that can be expanded. We saw a lot of investment dollars spent earlier in the decade on promising digital health companies that never quite made it to market. And so one of the biggest things, for these early companies is making sure, hey, a lot of times the physicians are not going to be the purchasers, but they're the stakeholders. So it needs to be something that's usable for them, makes their lives easier. there's a recent trend called click neutrality, where we don't want another tool. We don't want to have to open up another screen. We don't need another burden. We need something that integrates, but we have a chance to work with these companies, give them feedback, but also collect data, something that helps them as they work towards FDA clearance or work towards CMS coverage, which is helpful for the early companies, but also helps us be aware of early companies that are meeting our needs and our goals, and work together in a synergistic way.
Yeah, kind of to add to that, I think as physicians and physician leaders and executive physicians, we have this unique opportunity every time we enter into one of those conversations to be the consummate advocate for our patients, right, and other physicians. And so sometimes I think when those priorities are at odds, if you think back just to, right, when it comes down to it, medicine very simply is for the patient. And we all became doctors to help a patient. And I think that sometimes that breaks down some of those barriers a little bit. And so that's why it's always nice to have physicians in those important conversations. Otherwise, we've all been a part of places where, initiatives have gotten pushed forward without the physician voice. And just like technology, if it tries to get pushed forward without a physician voice, it will fail, right? And so I think that that's kind of how you break down some of those barriers, is you come back to say, is this good for our patients? And if it is, usually you can find some common ground there.
I think I'm most thoughtful about prioritization and how we align priorities and how we make sure that we're all walking towards the same goal. We struggle with, sometimes there are strategic goals that are put in front of us that we may not necessarily understand, that don't align with where we want to go or what direction we want to go in. And so I usually step back to what problem it is that we're trying to solve, and how we can partner with our operational colleagues and our clinical colleagues to come together to create a solution, as opposed to bringing forward a solution that's looking for a problem. And so I'm not sure if I answered your question, but I think it's really alignment of those priorities. And I think that I heard this morning from this morning's panel how you use service lines and how those service lines can help craft priorities together with IT in the room to really make sure that we're all marching in the same direction.
It took a little bit of time to think through what conflicts we manage, because for the most part, people are really oriented towards the quadruple aim, and so it's good, fun work, because we like making patients happy, we like making clinicians happy, we like financial health. So in general, the conflict ends up, maybe, if you can call it conflict, at the line where you cut off what are you going to be able to invest in this year. And because we can't support everything all at once, and we can't support everybody's priorities all at once. And so we have to pick the priorities that best align with the overall business strategy and where we think the most value is. And that takes a lot of thought. And sometimes people who work in healthcare IT see opportunities that the folks who run operations don't see, because the folks who run operations are never going to understand the healthcare IT as well as the IT folks. And part of our job is to do the translation and explanation and get to the place where we're all in agreement about this is the direction that makes the most sense for us. I wouldn't call it conflict. I would just call it a lot of work. The other area that comes to mind when you think about conflict is an age-old dilemma, which is, on the one hand, there's no end of demand to make it better. People are constantly asking for us to make it better. And they're also asking us to stop changing things. So balancing that is pretty tricky. And takes a lot of explanation sometimes, because when you're, KP has almost 300,000 employees, and when you're dealing with scope that large, once you've made those prioritization decisions and you've made changes that hit folks in the, wait a minute, you mean I have to learn a new way to do my job? That can create some angst, and we have to manage that.
So let me ask you a follow-up question on that, a couple of follow-up questions, and you guys can jump in. The first one is, you mentioned a really important tension, right? People want to see improvement, and yet we often hear the "don't move my cheese" comment. How do you manage that? What are some strategies that you've found that are effective? And then the other tension that we often feel is the cost versus benefit tension. How do you manage those things?
So along the first question, like how do you manage the tension? I think you have to be really intentional about where you're going to improve. One of the biggest things in biodesign is you start with a need. You start with a big need, because as you mentioned, you don't want someone to bring something to you and say, this is a solution that's looking for a problem. You want to start out with your greatest need for your patients or for your department. But once you have that, the next thing you need to do is be very intentional about the pilot. We've heard about all these pilots that get set up and they don't recruit enough patients, or they don't run long enough, or they don't have very specific goals. And I think you need to set that at the very beginning. Say, we're going to work together for this period of time. We need to get this number of patients to get any kind of statistical significance, or to see if it's moving the needle at all. But that's a major factor for how you can make sure it's an effective way of working with your time and working with your partnership and addressing those service lines.
Yeah, to add to that, I think that setting up those mutual goals are super important, so that your clinicians understand what it looks like, as well as your technologies understand, like, what is success here, right? So if you think about it and you go, all right, well, if value is quality over cost, are we looking at cost measures to call this a success, or are we looking at quality measures? And then we have to agree upon what is quality here. You had a good point when you were bringing up some of the cognitive load for your physicians, and some of this is hard to measure, except for we know that physicians are burnout, and it's not just physicians, right? It's their staff. So are we implementing a solution that can help with that whole care continuum, and making sure that we're getting those metrics right, so that we can, again, all be able to identify success at the other end?
I think it's really important. I'm going to double click on the partnership and collaboration thing, right? I mean, it's super important to partner and collaborate with the people who are at the sharp end, who are delivering the care, in order to effectively implement change. And so if you don't include them in the conversation from the get-go, I think it makes for very difficult times for any organization trying to implement that change. But I also want to reiterate what Brian said here, which is no one knows IT as much as IT, right? And so at some point there does have to be a deference to expertise, and so, but that deference to expertise has to be earned. It's not given, and I think it's earned by successful execution, and so. We have to earn that trust. We haven't necessarily earned that trust yet, but I'm hopeful that as we get more physicians into this space who understand patient needs and physician needs, that we'll be able to move further along that journey.
Learning how to do healthcare IT is daunting. When I bring somebody new onto the team, I tell them it's like starting a fellowship, and it can take several years to learn this, and that is counterintuitive because everybody uses healthcare IT, and everybody thinks they understand healthcare IT. So one of the things that we did to solve this change management problem was we recruited about 1 in every 10 physicians to be part of healthcare IT. And this is something you can do in Kaiser Permanente that I don't know if can do in other organizations. But we basically made it so that if you're working within a department, if it's a large department, chances are at least one doctor in the department has extra technology training and is linked to the technology teams. And we do this along specialty lines. So, in the world of adult and family medicine, which is what we call, family practice and internal medicine, there's one person who chairs that whole arena and works really closely with the center group, who are the core informatics docs. And then that person works with actually several hundred adult and family medicine kind of technology experts. And we really rely on these folks as both since there's docs here, efferent and afferent, to help us understand, what's going on with the end users and the folks who support them, and what do they need, and what do we need them to know when we're introducing changes. So the key to all change management for us is tap you on the shoulder and talk to you in person.
I love that. That's fantastic that you are gathering the voices of your clinicians to try to understand what is the problem that we need to solve. And there are a lot of folks in the audience that may be asking, what are some of the things in your organizations that you're tackling? Because our solution designers here really want to understand what are the needs that clinicians have. And so I'd love for each of you to share a few of the needs that you're thinking about today and potential technology solutions that you would be interested in learning more about.
As an emergency physician, being able to get up to speed on a patient very rapidly is very important to me. So, if it's someone that's already been seen in your healthcare system, it's not a big deal because you've got a good record in your electronic system and you can see their history. What's more concerning is if you're seeing a patient that's from a different area, or they're traveling, and you're new to them, you need to have a way to get up to speed really quick. And so we talked about pain points earlier. One of the things that I really am interested in is interoperability of health data. I actually consult a group called Zeus that's focused on doing that for transitions of care. So do you think that makes life easier? We were talking about, what's good technology, what's bad technology, and a colleague of mine worked at a hospital where they're like, our physicians are so burnt out, we got to help them. And so they made them all download this app, and then they had to log whether they use the app to meditate. And it's like, you just gave them 2 extra boxes. And that's not helpful at all. But things that help with your flow, and that's one thing that I talk with companies about when I advise them, is to talk to physicians early on and say, is this, number one, is this a pain point for you? Number two, how do we seamlessly integrate this into your workflow? Because that's the key, otherwise it's not going to get adopted. And so I look at, that with all the hype with AI, I think there's a lot of great opportunities that are there, but I think the big things are for operational metric tools. Like in the emergency department, can we match, can we use some predictive analytics so we can figure out where are our volumes, where are we staffing accordingly, are there ways to transition that, and things along those lines with operational nature. So I think there's a lot of benefits for AI. I'm really interested in interoperable health data. Those are areas of interest of me that I have.
So a quick story about a company who asked me my input about their product. They said, hey, we built this amazing product, but doctors won't use it. Why won't they use it? And I said, well, how many doctors did you have involved in building it? They're like, oh, none. I said, there's your problem. So I think that you have a great question is, what are we thinking about within practices and what are some of the needs there? And I'll tell you, we have so many point solutions that push into practices. So many, it becomes countless, right? And there is human glue that is holding all of those things together. And so I'm thinking a lot about, so physician burnout obviously gets pushed way into the spotlight, but I'm looking at, MA turnover and front desk turnover and all of those pieces that actually complete the care journey. And how are we keeping all of those really important people engaged in healthcare and taking care of patients and building technology that takes away some of those point solutions and looks at the whole continuum. And I think that, your point to interoperability and getting some of those records is really important, because that, again, is just kind of one more piece to it. So I think that those clinical efficiencies are always on my mind, because I think that that's part of what stresses physicians in their office, whether they don't have the records, so I can't care for the patient in the manner that I want to care for them, or they're running behind and it's, they're sitting there waiting to see a patient because they're stuck somewhere else in the system. So that's really, I think what weighs on my mind when I'm looking at a lot of these technology and AI solutions and where they can help with that process.
Yeah, I'm going to double click on the data and interoperability. Our hospital system is half of our hospital system is in Northwest Washington. In Northwest Washington, we have at least 2 instances of Cerner and probably 7 instances of Epic. And if you look at those 9 different instances of those major records, I can guarantee you that there are 9 different medication lists, and they don't align. And why are we still at a point where we can't provide a single source of truth for something as simple and as important as a medication list? It's inexcusable at this point that we haven't been able to get that data distilled from electronic health record data, pharmacy benefit manager data, pharmacy data, claims data, in order to provide a list to our physicians at the right time, at the right place, and the right patient, so that way we can provide the right care for that patient. Okay, I mean, I'm a urologist. I hate DOACs. I'll never like DOACs, but they're going to remain on the medication list, and I need to know when they're taking them and when they last took them. And if we can't provide that kind of data to our physicians, we haven't done them a service. And so that looking at the data across these systems and being able to provide a single source of truth is the windmill that I will continue to tilt at.
Okay, so I like DOACs. Oh. But, and for those of you who don't know what they are, don't worry about it. I think that every organization has the challenges of, what's their technology debt, what's the history, and how did they get there is such an interesting story. But, now, okay, yeah, now this is what you have. Now, for example, with us, in California, we're divided up into our Northern California and our Southern California regions, and they're so gigantic that when we deployed Epic 20 years ago, we had to deploy 6 instances of Epic in each one of the regions. And so right now, we're undergoing consolidation into 2 California regions because we're still too big for 1 California instance of Epic. It's going to be 2 instances of Epic. That's a really great example of some of the challenges that you face are just kind of what did you inherit from what was possible in the past. And then other challenges that you face are like, what are you inheriting from opportunities of right now? So figuring out how to use AI is a really fun problem. It's a really fun problem because there's some incredibly exciting things that we probably will be able to do with AI. And then you have to figure out, is like now the right time, or are we ready to jump in with both feet, or should we wait a while because what everybody told us we should be doing last year is different than what they're telling us right now. So there's a tremendous amount of historical burden and a tremendous amount of now burden that's based on just the legacy and the uncertainty. And mapping your way through that is a big part of the job, especially because turns out everybody's got an opinion. And everybody has a little bit different information. And so making these decisions in uncertainty about these very complicated things is a lot of work, especially if you're in an organization like mine, which is consensus-driven.
You've each highlighted a lot of the challenges that we're experiencing in the clinical spaces. I always remind my colleagues that we are no longer chasing paper charts to get the vitals for the patient. So that is a win. We want to highlight the wins. And we have all of these pebbles in our shoes on a daily basis that each of you eloquently described. And we have a lot of technology designers here that probably approach you regularly with solutions to some of the things that you had mentioned, often offering pilots. I think the concept of a pilot, most folks have an opinion on, and so I wanted to ask you to share your thoughts as you are approached by potential solutions. What are some of the things that go through your head? What is the most optimal way for you in your roles to partner with solution designers that are hoping to pilot their technology in your organization?
Sure. I spoke a little bit about this earlier, but I think the big thing is it has to be something that addresses a pain point. And so that, rather than, scattershot and saying, oh, we want to just try cool stuff in our ER, we're really specific, saying we're trying to solve problem A, B, and C. Are there companies in that space that are addressing that? How are they looking at it? Do they have data from other partners that they've worked with? And if that's the case and it's a good fit and we bring them in, we want to be really intentional about that pilot. Like, here's our goal, in our department. Our goal is to, fix this problem. How does your solution help with that? And I think if you start out trying to tackle your big problems, being very specific about who you work with and what their methodology is, and setting goals together, I think that's the best way to do it. Jen mentioned the company that didn't have a physician on board, and that's kind of like a big thing. For me, I talk to companies that either have physician founders or physician advisors. If you don't have a physician at some level, you're a tech company. If you have a physician, you're a healthcare company. And so that's a huge thing for me. I want to work with companies that have done their research and have the right folks involved in forming their decision of how they're building that solution.
I think that's really well said. Are you a tech company or are you a healthcare company? And so when I look at pilots, I look at it very surgically. Risk, benefits, alternatives. What are the risks of me doing this pilot? Have you done it other places successfully? How much are you going to interfere with the current workflow? What are my security risks associated with it? And then what are the benefits, right? Like, what's the problem that we're trying to solve? What are the metrics we're going to be there? And the alternatives. Like, if I don't do this, what will happen? Or is there another solution that's similar? And so I think it's kind of a good framework to go into it with. And yes, like, if you're getting ready to pilot into a practice or into a hospital, what experience do you have with understanding that, right? It's like, if you want to go and tell a restaurant what they should do in their kitchen, but all you've ever been is a patron and eaten their food, and you've never been a sous chef, you've never been a hostess, you've never been a busser, you can't tell them what to do, like, behind closed doors. I think the same is true in healthcare, is you really have to understand where that fits in operationally, because the pilot will fail every time if you interfere with where they are.
I'm going to go back to don't be a solution looking for a problem. Partner with our operators, partner with our physicians in order to develop a solution to a problem that is a pebble in their shoe. Now, one of my CMIO friends in the Pacific Northwest, he says that he's the CMI no as opposed to CMIO. So I think that the other part of that is that don't make me into the CMI no. Make sure that we're part of the conversation when you are with those operators or with physicians coming up or partnering with a solution to their problem. Because there's many a time, right, where I have to say no because they didn't make it through a vendor security questionnaire because their coders were in the Ukraine. I mean, and my CISO said, we're not doing this. We can't do this, Mike. Okay, so get us involved. Get informaticists, physician informaticists, healthcare informaticists, nursing informaticists in early on the conversation. We have had vendors literally tell our operators, oh, don't worry, you don't have to talk to IT. They can integrate this. It's so easy, okay? Don't say that. And so, but again, it's about partnership. It's about collaboration. If you engage with physicians, operators, and informatics and IT, you will get a better result for your pilot and for a long-term relationship, because that's what you're really trying to form here.
I agree with all those things you guys said. I think a pilot's in two ways. There's we're going to deploy something big, but we need to learn a lot more about it, so we're going to pilot it ourselves. And chances are that's not the type of pilot that you're talking about that the vendors are that interested in. But that's really important for us because there's a lot we don't know that we're going to learn. And when we do spread things, we spread it massively, and we better have learned it's like test flying an airplane before you mass produce it. The other kind of pilot that I just agree with what you said, that when vendors, salespeople, account executives go to operational executives and tell them it's going to be easy, and we'll just pilot it, at your facility or in your department, that is a really good way to alienate the IT executives. The chances are you're going to lose some credibility when you do that, and you're going to lose a lot of trust. So I do not recommend that. You can get the interest of the ops executives and have the ops executives come talk to us about it. And unfortunately, that may not lead to a sale, because we're going to probably tell them, well, no, we have this other plan that's coming that you hadn't heard about. And they're like, oh, I didn't know about that. But once a pilot has started out in the field that we don't know about, the IT immune system is going to probably try to eradicate it and then build up defenses against it.
Love that. I was hoping that you bring that perspective from the CIO lens, so that's fantastic. Can you share, as a follow-up to that question, some of the metrics that you're thinking about, both quantitative and qualitative perhaps, as you're evaluating these technologies?
One of the most important things in the emergency department is time. Like if I have 6 patients that check in an hour, I got to get up to speed, I got to see them, maybe some of them are going to need procedures. So anything that saves me time. And so that's a nice, easy one. You can have it in minutes, and that's a nice way to do it. The other one is you can look at things like if you have a specific problem that there's an administrative burden, and this goes back to time as well. Is this a solution that takes away? Is this a solution that gives me more time with patients, or is this a solution that's like another thing I got to click through, and it's another administrative burden, and so I'm away from patients? So that's really how I evaluate it. Is I need time in general, but particularly time with patients as opposed to time at a computer.
Yeah, I think that we all want more time. So I think that that's an incredibly valuable metric anytime you're putting it in there. You said, click neutrality. It's not even like a sum zero game, right? You want a negative game at this point. And so those are some of the things that you can measure. I think that satisfaction scores here matter too. So if patients are involved somewhere in that technology, I want to know that the patients thought that this was a good experience. I care a lot about that. One, because it's not the tech company that's going to be seen as good or bad based upon that interface. It's my practice. It's me. And so I think that's really important. It's also super important to me if it goes through the staff, or if it's physicians that are interacting with it, like how satisfied are they with it? Or is it more frustrating or stressful for them? And then I think that you do need some other hard measures, and that's where it just sort of depends upon the product and how you measure quality with the product.
I think that it depends, right? And so top line, we're always going to go to, well, does it generate revenue? And usually most of these initiatives don't generate revenue. They're not accretive. Well, then does it save cost? Okay, are you able to repurpose FTEs to a different role? Are you able to save money elsewhere? And be very intentional about making sure that you follow through with whatever it is that you put in your pro forma. And then I think equally important is well, how did it impact the physician? And I think that a lot of us have gathered a lot of really good data on ambient clinical documentation. And it certainly aligns with what I heard this morning. At Multicare, we have not seen an overall decrease in the time in chart, but we have seen a decrease in time in notes, and we've seen an increase in chart review and an increase time in orders. And so for me, if the primary care doc is actually reading the urology note, that's a win, right? Because it's the most important note in the chart. Okay? Maybe not, but I think that can feed the narrative that our physicians are doing the more important action-oriented things in the chart as opposed to documentation. And finally, I think it comes down to, and we're continuing to survey our physicians as well in terms of their satisfaction with the electronic health record and different initiatives on a micro basis. And so I think you have to include all of those sorts of metrics in the way that we look at how a solution is good or not so good.
Metric design is really hard, especially prospectively. It's easy to just kind of lean back and say, well, it's all financial, but a lot of times what the finance executives think is measurable financial wouldn't be measurable to patients or physicians. And so it can become really challenging to get on the same page about that. And part of the strategy is to articulate to all these different stakeholders who have different ideas about what they might measure, what the higher goals are and how those higher goals align with the overall organizational goals. And really the cultural identity of the company. Who are we and what is it that we're trying to accomplish as a mission together? That's hard to do because some of that stuff is really hard to measure. The other thing I'll mention about metrics is that if folks come at us with, well, here's a set of metrics that we should apply to every project, it's like, no. These projects are really different. They work in different parts of the organization. And when you're caring for a population of patients, the diversity of the population we're caring for is, not just the diversity as we all think of diversity, but the diversity that we're talking about pre-birth to end of life and everything in between. It's just too overwhelmingly complicated to say, okay, let's apply a single, high-level metric set to that. So we need to be smarter than that. And so I really try to be careful that we don't take simplistic KPIs or other kinds of things and use those because they end up mixing people up about what we're really trying to accomplish.
Thank you. All really great points. We've spent a lot of time today talking about how can technology support the physician day-to-day workflows to care for patients. I do want to ask one final question before we get to audience questions and discussion time. One of the topics we talk less about is the evolving payer practices and the physicians' need to navigate the changes in payment and reimbursement. So can you talk a little bit about your view of the role of technology in supporting these payment models that are changing?
I can address that from my advisory role with Zeus. One of the things that we look at is we bring a lot of structured data together. And so that's very nice. If you're doing a transition of care for a patient, you can see what their history is and how you can address that. But the other nice thing is if you take a panel of patients, you can also go through that and say, for your annual wellness visit, how many of these patients have not had a hemoglobin A1C this year? And rather than setting appointments by, who's ever calling or who's ever making the appointment, be really intentional about saying, well, here's 15 metrics we need for the year. Let's make this appointment with this person that's missing 5 of them. Let's get a plan to get that done before the end of the year. Because a lot of it are situations, particularly with CMS, where if you don't have particular boxes checked, you miss out on that reimbursement in general. And so I think you have to be really proactive in saying, let's address these active concerns of the patients that we have, but at the same time, as things shift toward prevention models and a certain amount of money for a panel of patients, I think you have to be really careful how you're utilizing your time and spending that with the patients to make sure you can kind of maximize their health, and then also in turn that should maximize your reimbursement as well. for my emergency department hat, I can't really speak to that. I get paid when I show up and I take care of patients, and sometimes they have better insurance than others, but I'm always there, and I don't really have the option of saying, I'll only take care of these patients today, not these. But if you have a group practice, or particularly if you're another type of specialist, it becomes very critical how you address the patients that you see and how you maximize your time with them.
Yeah, so if you think about data out of an EHR, 80% is unstructured. For those who don't know, like unstructured data, right, is all the stuff we write. And it's very hard to glean value and understanding from that information. So, when I started working with Ally Health, that was one of the priorities, was making sure that all the patient information we had came in as structured data. And then you have the opposite of that, which is, the massive amount of data that you have. It's like Rhyme of the Ancient Mariner, right? Water, water everywhere, only it's like data. And what are you going to do with all of that? And that's where you need technology. You need technology to help you with, the price transparency that came out. You need technology to help you build better algorithms, build, risk predictors, all of those parts to it, so that you can be very smart about how you go into it and how you enter into these, new types of contracting. Otherwise, it's just easy to kind of fall back on what you know, which is the constant fee for service. And so I think that there's a lot of potential for AI and, for technology to support those efforts.
I think I may have understood the question a little bit differently. I think that at this point, I think that AI, and we'll call it AI, right? That it's most applicable to the administrative tasks that physicians don't want to necessarily deal with. And I do have some concerns, and I'm thoughtful about the fact that it's super sexy for GPT or Gemini to go and take the board exam and score better than 95% of fourth-year medical students. And it's certainly interesting and certainly compelling. But when I sat for my informatics boards, there was reading on the AI winter that I think that most of us lived through, because I still remember in the 1980s, I read a Discover magazine article on artificial intelligence and how it was going to change everything. And we all lived through the AI winter, right, where we didn't hear a peep from them, right? And part of the narrative in healthcare was that we were hyper-focused on the Greek Oracle version of AI, that you're going to have your diagnosis and your treatment, and they're going to be way better than a doctor. Right? I'm going to ask us not to focus on replacing doctors, right? I'm going to ask us to focus on the stuff that doctors don't want to do in order to make them better doctors. And those are the administrative tasks. Those are the rule-based revenue cycle issues that we deal with on a regular basis. And I'm not sure if that was the question that you were trying to get to, but that's sort of what came to mind.
Feels like we're playing telephone because the question has morphed as it moved down the line here. But I'm going to come back to this thing about payer. And one of the reasons I love working at Kaiser Permanente is because we're a single payer system, and we're not fee for service. And folks aren't getting pre-authorizations and other things that are very, very burdensome in other healthcare organizations. So we're really interested in how to maximize access, maximize quality, maximize patient satisfaction, maximize clinician and employee satisfaction. And so there's something wonderfully pure about that, because satisfying payers is something that's very challenging. I imagine that my colleagues have to think about that constantly, and I just don't. So let me just sort of celebrate that. The KP model is fantastic in that way, but there's still lots of things to be challenged by, even though we're not focusing on the payer challenges.
That's fantastic. You guys answered many aspects of the question. Thank you. And so with that, I'd like to give the audience an opportunity to ask some questions, and we wanted to tee it up from the various perspectives. And so from the physician perspective, what do you wish technology solution designers understood? These 4 physicians here had shared their thoughts on what they wish that technology designers understood. And anyone in the audience that is coming from the company perspective, what questions do you have for us, for physicians, about the solution that you're designing? And I can't see the audience, but I hear there are microphone runners. So let's start with questions, and everyone on the panel can weigh in.
Hi, my name is Peter Thorson, and I work for a software company called Tendo Systems. And my question for you, there are a couple of interesting points that were raised about change management and interoperability. And a lot of tech solutions that are out that are kind of on the bleeding edge of trying to use some new tools and techniques that are available, they typically will want to interoperate with the legacy systems that you find in the healthcare system. Sometimes that interoperability can be difficult, and I'm just curious, what your perspective is in advocating for interoperability between some of the newer solutions that are out there and some of the legacy systems that are part of the infrastructure.
I think that interoperability, one, it serves as far as like health information. That's where we talked a lot about interoperability and the need there. When you're talking about new technologies and its ability to integrate with systems, it's really us, I'm going to say like us physicians requesting less clicks, less extra, programs to manage, and for practices too, as they're, again, kind of looking at all these different point solutions. So there's interoperability with regards to healthcare data, and then I think there's interoperability or integration with current legacy systems that allow us to continue to be efficient.
Anytime an operator comes to me with a new piece of software, a bright shiny new object, integration is our biggest bottleneck. I'm not 100% certain if you're talking about integration at the health system level, or if you're talking about greater interoperability with some of the giants that house much of our data at this point, and how well they play in the sandbox with some of our newer software brethren. Is that what you're?
Yes, he said yes.
Yeah, I think that I started by saying that we need more interoperability and we need more integration. And in the end, I would like to, and this is my naivete coming through, but in the end, it's our patients' data, and so they really should be a significant stakeholder in terms of determining how that data is shared. But yeah, I have to say that I'm hopeful that we move to a more interoperable, integrated framework.
There are different schools of thought about this. And even just this morning, I was in a vigorous discussion with some super smart people who have different points of view about this. There are certain giants that we work with, and one of the things that somebody like in a role like mine has to think about is if there's a new entrant who's advertising something that's potentially attractive, how long will this be attractive if one of the giants is going to be going in that direction? And the other question I have to ask myself is, could a new entrant accomplish this outside of a data model that might belong to a giant, where I have to send data through APIs to be able to interoperate versus doing it within? And so You know, these are questions I ask myself all the time. That does not mean that there isn't a role for vendors who are not part of one of those giants. We use lots of vendors who are not part of one of those giants, but because we need to, you know, the software must work, you know, there's going to have to be some really compelling workflow benefits for doing it, and it's probably not going to just be based on a single idea. It needs to be based on, you know, kind of an ecosystem that would not work within one of the giants, or would take one of the giants a very long time to accomplish, and that solves a really important business problem that we want to solve.
If I could just add an additional thought to that, this is a question that I think comes up all the time. So I love that you asked this question, because it's this balance of innovation which we want to make sure we don't forget. We need to think about creating new technologies and integration into workflows. And you heard a few people today mention workflow. Workflow is everything in the clinical spaces, and so if it can't be seamlessly integrated for the clinician to have that experience, they're not going to use it, and we're not going to get adoption. And so there's often that balance of, is this so new and innovative that you can bring it to the healthcare environment and seamlessly use it until it is developed by the technologies that are existing, or will they get there faster? And I think that's the question a lot of CIOs, CMIOs are asking themselves.
Or will they never do it? Because
Right.
it's something that they're just, you know, ill-equipped to do, or they're not going to do for a variety of reasons. All of those things, there's examples of all of those things.
Yep.
Oh, yeah. Just along those lines, with the workflow integration, I think of the tools that are so great and so useful to me that I'll open up a second screen for them, and that's UpToDate and MD-Calc, and those are resources as far as treatment management, and MD-Calc are algorithmic tools as far as taking care of patients. Those are big enough pain points. I'll open up another screen, but other than that, I want to stay within my record, and you know, it has to meet a major pain point for me to take an extra step than I would outside of my other workflow.
And even those I've been asked to integrate many times.
Yeah.
Yeah.
If we could bounce back to the slide, the questions for companies, it's what are the questions that you have for physicians? And then physicians, what does it take for it to be successful for you? Any questions on this side of the room for Laura's microphone? And then I have two over here. I see you two. Thank you. Okay, we'll bounce over to Laura and then over here.
Yeah, first of all, thanks for all the insights so far. My name is Rishabh. I'm a founder at a startup. My question was, at what point, once you've identified a problem, right here, once you've identified a problem, do you actually explore external solutions as opposed to trying to figure it out within your team? How do we solve this?
I think it depends. So I use a build, borrow, buy framework. I heard the maker, shaker, taker framework yesterday. I think that both of them apply here. For my organization, Multicare, most of the time, I don't think that we're in a position to build very advanced tools on our own. My friend from KP, probably a little bit different. And so we are generally in the borrow, buy category. And so if there is a compelling problem that we have prioritized, we've aligned, right, and prioritized that problem as something that we want to address, then at that point, we can go down one of two paths. We do have a very small venture arm that we leverage in order to find partners to collaborate with and come up with a solution together. We can be value-added investors. We can serve as God, I hate this term, pilot site for said technology, and possibly help you monetize it or market it on the back end. And then there's the buy solution, where there's already an industry leader out there that we really want to engage with. And a lot of times it's going to be, quite honestly, our operators or our physicians coming to me saying, hey, this is something that we really need. We'll use MedCalc or UpToDate. I mean, we have, but it was something like that where there's just a no-brainer. But that's generally how I approach that. We do tend towards trying to use technology that's already in our stack, and so we'll look within before we go out. But again, I do think that we are more in a borrow-buy as opposed to a build.
It's an interesting question because it goes back to build or buy, right? And I think it's going to be what's less expensive for that healthcare system. Do we have the resources? Do we have the folks that have the knowledge base? Do we have a big enough pain point that we can just build it ourselves? Versus, are we kind of a little bit behind the 8 ball, and this is a problem that's so big in the market that somebody's already built a better solution? And so there are 23 or 24 hospital venture funds, and it's interesting because you look at them, there's a mix of some try to create their own technology within their health system. They spin that out and sell it to other health systems. And some, like Intermountain that I advise, they say, listen, we recognize that there's a lot of great solutions out there already. Our doctors are busy, our tech folks are busy. We're just gonna partner with a company that's already building something great. We'll integrate it into our systems. And so I think it's a mixture. The way that question's answered is a mixture of the culture of your hospital, how you guys do it. But I think it's what's an easier lift? Do we have the tech here, or is someone doing it better and we can just bring that in-house?
Great. We have another question over here.
Hi, I'm Leah from Hackensack Meridian Health in New Jersey. So my question is about your tech stack sprawl. How are you managing that when providers tend to lean towards more bespoke options for their practices? So for example, what I just saw on the stage was you've got 2 docs right there that can't agree on oral anticoagulants, and then maybe John wants Nike sneakers for his trauma team. How do you enable each provider to work most effectively using the tools that they prefer without having one of every option that's available on the market today?
So just to repeat the question, is you're asking, like, when you have this large tech stack and one physician wants Nikes and the other one wants ASICs or what have you, and how do you not get it down to that personalized level? It's really hard because I will tell you, like, doctors are picky, right? Like, and we all have our own thing, and we think that the way we like it is the best way. But I will tell you, I have worked with some tremendous technologists out there, and the ones who are the best are the ones who can help your informatics leaders, your healthcare leaders, to translate that, because a lot of times it's just a misunderstanding almost in what the physician needs. And so that's where I would say the issue is getting down to kind of like a little bit of root cause to understand why one doctor wants one thing and the other one wants the other thing, and there's likely a solution that can cover both. And if there's not, then you get to some of the prioritization that we talked about earlier, and needing to understand the priorities within the business, so that if one is 10x more expensive, those bells and whistles may not bring the same level of value. So I think leaning on your technology folks is super important, and those who can translate what the physician wants into what the technology can offer.
We have a concept inside of Kaiser Permanente called Permanente Medicine, and it means a lot of things, but one of the things it means is that we have an identity as a shared, large, multi-specialty group with shared values and in a kind of a commitment to this idea of what we call group intelligence. And one of the aspects of group intelligence is that we are going to be much more effective in lots of different parameters that are very useful if we all kind of are moving in the same direction. And so that means that this ASICS Nike question, while perhaps highly relevant in our personal lives, is not particularly relevant within the practice of permanente medicine. And folks self-select. If they want to be, very independent, then be in private practice. But if they want to, get all the benefits of a large multi-specialty group practice and all the technology that comes with that, then come join us.
I want to double click on something that Brian said about having those departmental level SMEs or super users. I think it's really important to make them part of the conversation and help them to see how the sausage actually gets made. That I'm not the CMI no just to you, I'm the CMI no to everybody, right? And so we're trying to figure out what is the best technology that can be used across the system. And once they become a partner or a collaborator in that space, I think that they'll give you a little bit more grace in how that decision is made and why that decision is being made.
The Nike ASICS metaphor is interesting. I mean, if you guys watched Air, Nike was a running shoe until Michael Jordan. Maybe this company's going to have a big blockbuster. Maybe they got a big new, tech innovator that's going to take them off. At the same time, you look at ASICS. If you're a volleyball player, your track, star, or someone that's more specified in a specific zone, that may be the company for you. So, kind of running with that metaphor, that's how I would look at that.
Awesome.
Thank you. I think we're going to start to transition to our next panel. What I wanted to say is that I love the Nike versus ASICS question. I think the real question has all the other brands in it as well. For any CMIO at a health system, they're managing so many different choices. And as you heard, having governance and a process for how you make those decisions and having some guiding principles is very helpful. I've been at institutions that have done this well and institutions that have struggled. And I think setting the expectations up front has always been incredibly helpful. I want to just take a minute to transition to our next panel and thank our panelists for sharing their wisdom and experience. So we talked a lot about thoughtful technology integration, and you heard firsthand experience of ways that we can do this well. And when we think about bringing these newer technologies and new modalities of delivering care that rely on technologies, so virtual care and hospital at home and RPM and all of these new modalities, and we think about the evidence that we need to then drive reimbursement, because ultimately, as the technology is evolving so quickly, we need to make sure we as a healthcare system are ready to deliver care in those modalities. As you might know, the AMA has the CPT code set that helps us define the services that have been delivered and is a way for us to then track the value that these services are providing. And as we integrate the technologies, it's going to be more and more critical for us to gather that evidence so that we can expand these programs and drive policy and payment. And that is precisely what our next panel is going to discuss: digitally enabled value-based care. And so I would like to invite Tom Castles to the stage to introduce our next panel. Thank you again to our 4 panelists here.